or ventilatory failure. Hypoxemic failure, that is a type 1 respiratory failure, or when there is in the body there is a decreased PaO2, oxygen is not sufficient. So what are the conditions? When there's a pneumonia, ARDS, congestive heart failure, pulmonary embolism, and also remember COVID. These are all type 1 respiratory failures. Whereas type 2 respiratory failures or ventilatory failures, where you see the increased PaCO2. It is seen in conditions of COPD, asthma, acute intoxication, and neuromuscular blocking drugs, and obesity, hypoventilation. All these things, what we discuss for NIV, all these are ventilatory failures, which we commonly use. This is for mechanical ventilation. Then, coming to the drugs, local anesthetic drugs, which are very important, lignocaine. Lignocaine is the most commonly used local anesthetic drugs. This is available in various formulations. So lignocaine, you see, lignocaine 0.5% is used for intravenous regional anesthesia. 1 to 2% is used for peripheral nerve blocks or epidural or infiltration. 2% jelly, what you see here, is used for urethral procedures, like when you are using for catheterization, Foley's catheter and all. Then 5% heavy. 5% heavy is used for spinal anesthesia. Nowadays, we are not using lignocaine-based drugs because of having transient neurological symptoms. We are using mostly bupivacaine only. And 4 to 10% is the sprays which we use it for topical anesthesia. Then this lignocaine has a preservative. It has a preservative and a methyl paraben. And there's something called preservative-free. Preservative-free drug is xylocaine, used in treatment of ventricular arrhythmias. Treatment of ventricular arrhythmias. This is about lignocaine. Then, again, this was a very important question, Yamla, asked in the recent NEET-PG examination. Yamla, eutectic mixture of local anesthesia. It is a composition of 2.5% prilocaine and 2.5% lignocaine. Once you apply, the effect comes in 30 to 60 minutes. Where is it used? So it is like a local anesthetic which you apply over the skin. You identify an IV cannula. Okay, it's there. You apply the cream and you keep the sticker here, the transparent one, and you leave it for 30 to 60 minutes. And after this, the hand will get anesthetized and you can easily cannulate. So this is used for IV cannulation in children, to antagonize the needle phobia, to anesthetize the intact skin. But it is contraindicated in cut skin or in the mucous membranes. So nowadays, even for in nose picking, ear picking and all, we are using EMLA. Then, very important, intralipid emulsion. Intralipid emulsion, or like 20% intralipid emulsion, sometimes 4 to 20% intralipid formulation or emulsion. This is used for bupivacaine-induced cardiotoxicity or in treatment of local anesthetic systemic toxicity. Very important. Thrice this question was asked in the last 4 years. More so often, like in the last 3 years, twice it was asked. Local anesthetic systemic toxicity. Last, use this. So when you give a local anesthetic drug more than what is required, see, usually for lignocaine, it is 4.5 mg per kg normally used. If you give more than, along with lignocaine, along with adrenaline, you can give up to 7 mg per kg. If you give more than that, it causes local anesthetic systemic toxicity. So in those conditions, for treatment of lignocaine or bupivacaine-induced cardiotoxicity, you give 20% intralipid formulation. If you can remember the dose, that is fine. Otherwise, also remember this intralipid emulsion, you are done with this. So usually you give 1.5 ml per kg bolus, followed by 0.25 ml per kg per minute infusion you can give. And remember, cardiopulmonary resuscitation post bupivacaine is very difficult to revive. And this is a print mistake. You just ignore this. Okay. Then, last or local anesthetic systemic toxicity. Last, very important. Last is local anesthetic systemic toxicity. You see with lignocaine and bupivacaine. In CNS, usually CNS is the first system to affect. You see the circumoral numbness, paresthesias, dizziness, tremors, and convulsions. Most common presentation. Usually we'll ignore the circumoral numbness, paresthesias, dizziness, and all we will ignore. And usually the presentation itself will be the convulsions. The most important thing is you have to maintain the airway and you can give the anticonvulsants. Whereas CVS, the most cardiotoxic drug is bupivacaine, and most common arrhythmias with bupivacaine are ventricular arrhythmias. The treatment for bupivacaine-induced arrhythmias are you can use amiodarone, procainamide, and beryllium. And this is very, very important for treatment for bupivacaine-induced cardiotoxicity, 20% intralipid formulation or emulsion. And the cardiopulmonary resuscitation post-bupivacaine is post-bupivacaine toxicity is very difficult to revive, and we have to be very careful in this. Okay, this is lost local anesthetic systemic toxicity. This was a question which is more so often being asked in the recent past. Then, muscle relaxants. We know there are two types of muscle relaxant, depolarizing and non-depolarizing blockers. Depolarizing blocker, it is only example is succinylcholine. Non-depolarizing blockers, we have so many drugs like atracurium, cisatracurium, vecuronium, mivacurium, most of the drugs. So usually this succinylcholine, when we give the drug in a regular dose, it causes phase 1 block. When you give the succinylcholine in high doses, more than 5 to 10 mg per kg, then it causes phase 2 block. Non-depolarizing blockers always cause phase 2 block. Understood? So succinylcholine can cause both phase 1 and phase 2 block. Phase 1 in normal doses and phase 2 in high doses. Whereas non-depolarizing block always cause phase 2 block. So the train of 4, tetanic, post-tetanic potentiation, all these things are various types of stimulations. So which more so often we discuss about train of 4. In train of 4, in depolarizing block, there will be constant but diminished response. There won't be any fade. Fade is absent. Whereas in non-depolarizing muscle relaxant, there will be fade is present. Same with tetany. If you stimulate, if you say this, post-tetanic potentiation is also present with non-depolarizing muscle relaxation. Then what is the effect of anticholinesterase? When you give anticholinesterase like neostigmine, it reverses the block in non-depolarizing muscle relaxant, which is routine. Like to reverse, we use the anticholinesterases so that we can increase the action of acetylcholine. Whereas when you do the same thing with depolarizing blocker, it may potentiates the block for the reason it also blocks the butyrylcholinesterase. Understood? Then another very, 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 very important, which is also asked in the last NEET-PG, not as an image-based question, but it was asked as question of Sugamadex. One sentence which has the highest potential to be asked in the entire anesthesia is Sugamadex. It's which has highest affinity for which agent? That is for rocuronium. It is a wonder drug because it is CNS, it is modified gamma cyclodextrin, and it is the first selective relaxant binding agent, and affinity is highest for rocuronium, then followed by vecuronium, and then pancuronium. So modified gamma cyclodextrin is the first selective relaxant binding agent, highest for rocuronium. You can see this drug as a you won't usually get, and most probably you won't cannot get as an image, but it is modified gamma cyclodextrin, first selective relaxant binding agent, highest affinity for rocuronium, followed by rocuronium, and then vecuronium, and then pancuronium. It goes and binds the agent and brings it out. And please ignore this. Then coming to halothane hepatitis. For Sugamadex, remember one point, it has highest affinity for rocuronium. It is the first selective relaxant binding agent. That's it. Then coming to halothane hepatitis. Halothane is an agent, like inhalation agent, which is, it may cause halothane hepatitis, immunologically mediated. It is, halothane is stored in red color vaporizers. It is, once if halothane is given, it may cause in patients with autoimmune disease, and it may cause halothane hepatitis, where it causes centrilobular necrosis, and mortality is as high as 75 to 80%. And once you give it, it persists in the liver for more than 12 days. And remember, you can't repeat the halothane in the same patients within less than 3 months. Then coming to isoflurane, isoflurane is stored in purple color vaporizers. It doesn't have any analgesia component, and its odor is mild, irritant, and pungent odor. So we usually won't use it for induction, but we use it for maintenance. Its MAC, minimal alveolar concentration, is 1, and blood gas partition coefficient is 1.38. And it is the inhalation agent of choice for cardiac surgeries, neurosurgeries, controlled hypotension, and pheochromocytoma surgeries. Yes, desflurane also can be used for neurosurgeries, but it is most so often used considering the cost effectiveness also. Controlled hypotension is you voluntarily decrease the blood pressure so that there won't be any the bleeding, decrease chance of bleeding. And pheochromocytoma also because it has most cardiostable. Then sevoflurane, it is stored in yellow color vaporizers, poor analgesia. This is very, very important. MAC is 2, blood gas partition coefficient is 0.69. This is very important point. Sweet smell. And so because it is sweet smell, it is used for smooth induction, and that is why it is the agent of choice for induction in children and also for daycare surgeries in children. So if you get an inhalation agent, what is the inhalation agent of choice for daycare surgeries in children or induction in children? The answer is sevoflurane. Sometimes this sevoflurane reacts with soda lime at fresh gas flow less than 2 liters and forms a substance called compound A, which is nephrotoxic. This is another additional point. Sevoflurane, yellow color vaporizer, and remember it is sweet smell, smooth induction. Then desflurane, as discussed, its color of vaporizer is blue. Special vaporizer, text 6, and boiling point is 22.4. Vapor pressure is high, and but thing is it is pungent and irritable, and it causes unpleasant induction, so cough and laryngospasm. So we are not using regularly for induction, but we can use for maintenance. And MAC is 6, blood gas partition coefficient 0.42. And it is the agent of choice for daycare surgeries, geriatric surgeries, and obese people bariatric surgeries. Because it has less blood gas partition coefficient 0.42, it has rapid induction and rapid recovery. Because the patient will be under anesthesia for less amount of time, so we use it for daycare surgeries, geriatric surgeries, and obese people. So when we are discussing about MAC and blood gas partition coefficient for both the things, remember this. Our mnemonic Mahi HD, Mahendra Singh Dhoni, Mahi Singh Dhoni, Mahendra Singh Dhoni. If you go from M to D, what happens to MAC value? MAC value increases. Blood gas partition coefficient decreases. So MAC decreases. MAC increases means potency decreases. Blood gas partition coefficient decreases means speed of induction increases, speed of recovery increases. So ascending, descending sequence. So please be very careful. Mahi HT, MAC potency decreases, blood gas partition coefficient, speed of induction increases, and speed of recovery increases. Mahi HT. Clear? Then are you with me till now? Is the pace okay? Okay, before I take up the doubts, like what I thought is, in the next 15 to 20 minutes, so we have discussed like 70% anesthesia now, like 60 to 70%, like which are relevant. So I thought like, why can't we complete another 20 to 30% also, so that like there will be a complete thing. And what are the vital capsules which you will be reading up? I will quickly run through that, so that like in next 20, 25 minutes, you will complete that thing also, and you'll be confident about these things. Are you ready? Shall I start? After that, I'll take up the doubts. Intense focus, guys. So nothing to write about. Intense focus, like you complete auditory senses, like you should focus on that and go to that. See, as discussed, it's just about revision, guys. Nothing. How you can revise the entire anesthesia in next 15 to 20 minutes. So father of modern anesthesia, W.T.G. Morton, first successful demonstration by W.T.G. Morton. World Anesthesia Day is celebrated on October 16th. The term anesthesia is coined by Oliver Wendell Holmes, and the term balanced anesthesia is coined by John Lundy and Ralph M. Water. Then, ASA physical status classification, again, very, very important. It is built into 6 grades, 1, 2, 3, 4, 5, 6. ASA 1 is a normal healthy person. 2 is a patient with mild systemic disease. 3 is a patient not with a moderate, but with a severe systemic disease. And 4 is a patient with a severe systemic disease, but with a constant threat to life. And 5 is a moribund patient who is not expected to survive without surgery, and 6 is a brain dead. This is very important to ask it twice. So normal healthy person is a non-smoker, non-alcoholic, and 2 is a patient who is a current smoker. Examples: current smoker, social alcoholic, pregnant, BMI 30 to 40, and 3. Patient with alcohol dependence, BMI more than 40, and CKD and patient on regular dialysis. If patient has a history of CAD, transient ischemic attack, CVA, more than 3 months history, and even with the pacemaker is 3. But if a patient, ASF4 patient, if it's an irregular dialysis or patient with AKI, he belongs to 4. And if a patient has history of CAD, CVA, TA in less than 3 months, it is 4. And then patient with a sepsis and a disseminated intravascular coagulation belongs to 4. And ASF5 is patient with MODS, multi-organ systemic dysfunction, and the patient can't survive without surgery, like thoracic or abdominal aortic aneurysm rupture or intracranial bleed with mass effect. These are a few examples. If something suffixes 1E, that indicates ASF1 patient going for emergency surgery. ASF4E, the ASF4 patient going for emergency surgery. The E indicates emergency. Then again, important METs. METs is metabolic equivalent of task score. It is the rate of energy or oxygen consumption. Usually, normally is 3.5 ml per kg per minute. Remember one thing, METs 5 is very, very important. It is climbing one flight of stairs, like usually seen in dancing and bicycling. For us, METs less than 5 indicates poor cardiopulmonary reserve. This is one important point. Please remember. Modified volumetric reading, we just now discussed. MMP1 pillars, fauces, entire uvula, soft palate, hard palate is seen. MMP2 fauces, uvula without the tip, soft palate and hard palate. MMP3 base of uvula, soft palate and hard palate. MMP4 you see only hard palate. Easy intubation is seen in 1 and 2, and difficult intubation is 3 and 4. Remember with uvula, entire uvula 1, uvula without tip 2, base only base of uvula is 3, and uvula not at all seen is 4. Then what are the drugs which has to be continued and stopped? So all the drugs which can be continued. So anticonvulsants we can continue, and anticonvulsants and statins, digoxin, beta blockers, anti-anginals, and thyroid drugs, progesterone only pills, all these things can be continued. What are the drugs that can be stopped? Coming to anti-glycemic drugs, metformin less than 500 mg can be continued, rest all has to be stopped, and there'll be specific doses. Then very important, antiplatelets and anticoagulants. Aspirin less than 75 mg can be continued, more than 75 mg 3 days before surgery. Clopidogrel 5 to 7 days, warfarin 5 days, unfractionated heparin, it is 6 hours, low molecular weight heparin prophylactic dose 12 hours, and therapeutic dose 24 hours. Then coming to fasting guidelines, remember clear fluids in adults is 2 hours, semi-solids 4 hours, solids light meal is 6 hours, solids fatty meal is 8 hours. In children, clear fluids 1 hour. If 1 hour is there, not there, then go for 2 hours if option is there. Breast milk 4 hours, formula milk is 6 hours, solids fatty milk is 8 hours. Then we discuss this. All the gases are stored in gaseous form except carbon dioxide, nitrous oxide, and cyclopropane stored in liquid form. Pin index we discussed. 1525 is for 8, oxygen 25, nitrous oxide 35, carbon dioxide 16 and 26, cyclopropane 36, NOx 7, helium 24. And colors, gray body with white shoulder is air, black body with white shoulder is oxygen, nitrous oxide blue, carbon dioxide gray, cyclopropane orange, NOx blue body with white shoulder, and helium is brown. Then Mapleson circuit of choice for spontaneous ventilation in adults, yes. Mapleson circuit of choice for spontaneous ventilation in children, F. Mapleson circuit of choice for controlled ventilation in adults is D, and in children it is F. Very important. Then CO2 absorbers, we discuss soda lime 94% calcium hydroxide, 5% NOH, and 1% KOH, whereas Berylime, though the name says, is 80% calcium hydroxide and 20% barium hydroxide. And here the absorption capacity is 14 to 23 liters of carbon dioxide per 100 grams, and where it is 9 to 18 liters with Berylime. Then LMA first generation, you can see LMA classic, LMA flexible, intubating LMA, and remember these two things, AMBU ARA1s and AMBU ARA40, which was asked questions. This was asked this year and also the previous year. Last time they asked about AMBU ARA again, and usually I'll tell you, like, unless until you get an image, it is very difficult to identify, but again, I'm adding this, you can't miss out this. Second generation, LMA ProSeal, AMBU ARA gain, AMBU ARA flex. How you can easily identify with the first generation or second generation? They have like 2 ports, that is second generation, 1 port, it is a first generation. Then classic LMS sizes we discussed 1, 1.5, 2, 2.5, 3, 4, 5, 6. So please ensure that while writing down 1.5 and 2.5, please won't forget that. Then PVC endotracheal tube has high volume and low pressure. RAI South Pole tube used for cleft lip and palate surgeries. WMN tube used for single leg ventilation. Manual inline stabilization used in cervical spine injury patients. Celix maneuver used it during rapid sequence induction to prevent aspiration and pressure over the cricoid cartilage. Then oxygen delivery devices. Variable devices are simple face mask, nasal prongs, partial rebreathing mask, fixed venti mask, rebreathing mask, and high flow nasal cannulas. Nasal prongs formula, very important. FiO2 delivered is 21% plus 4 into fresh gas flow. Venti mask, maximum FiO2 delivered is 60% with the green color. Non-rebreathing mask, maximum FiO2 is 90 to 100%. HFNC image is very important. Maximum FiO2 is 100%. Flow rates 30 to 70 liters per minute. Just this point in the last 5 years got 12 questions. So Allen's test again also was a question asked in the NEET-PG. To assess the patency of ulnar artery, perfusion should be less than 7 seconds. If it is more than 15 seconds, contraindication for radial artery cannulation. Nail polish which give inaccurate SpO2 readings are purple, blue, and black. So square-shaped capnography waveform 35 to 45 mm Hg. There's controlled ventilation normal, inverted U-shape spontaneous ventilation normal, shock fin appearance seen in bronchospasm, ET tube obstruction or obstructive lung diseases. Cardiogenic oscillations are seen in children and thin chest wall. Curare cleft, spontaneous breathing in controlled ventilation. If in the middle of the surgery, administer muscle relaxant. At the end of the surgery, give reversal agent. Slow increase is seen in hypoventilation, slow decrease is seen in hyperventilation, rapid increase is seen in malignant hyperthermia, rapid decrease is seen in pulmonary embolism. Waveform not touching the baseline is carbon dioxide rebreathing. Flat line is cardiac arrest, acute disconnection, accidental extubation, and esophageal intubation. Sudden increase in ETCO2 while doing the CPR is increased return of spontaneous circulation. Bispectral index score adequate for anesthesia is 40 to 60. The most common neuromuscular monitoring is adductor pulses supplied by ulnar nerve, and most accurate is orbicular oculi supplied by facial nerve. Then malignant hypothermia, autosomal dominant, chromosome 19, mostly ranodin receptor mutations. Vigorous release of calcium from sarcoplasmic reticulum is there.